All right, let's move on. We're going to talk about oncology. So the subject kind of grows on you after a while. Anyway, sorry, wasn't a very good one. So what is cancer?
Rapidly dividing cells.
Yeah, so like kind of you said rapidly dividing cells. Is there any sort of like check and balance on the cells dividing?
Unregulated.
Yeah, no control over it, right? So it's unchecked cellular growth, right? So normally when you find tissues that are multiplying, they're undergoing mitosis, normally there's some sort of inhibition that occurs there. So maybe they outstrip their nutrient supply. They don't have enough blood supply to bring new materials to them to grow. Maybe they will have alterations of certain genes. So for instance, there's this one called P53 that actually triggers off apoptosis, which is what? Programmed cell death. I think if you take like undergrad biology, like you learn the mitochondria is the powerhouse of the cell, and then apoptosis is cell suicide, basically, right? So everyone knows that. Anyway, and they also lose what they call contact inhibition. So in some cases, you'd find that normally when cells are sort of surrounded by their own kind, they say, okay, well, I probably don't need to grow any further. They can lose that as well, such that they'll just continue growing and growing and growing until, boom, you have your tumor, right? Have you covered any cancer stuff in your medicine courses? You just finished, fantastic. So you're very well versed in all the meds and side effects, and oh boy. Okay, well we'll hit that today. Don't you worry. And again, you're going to find that we don't know the full etiology of all types of cancers. And when we say cancer, it's a very diverse set of disease states, right? So the way you treat a leukemia is completely different than you maybe do a brain tumor. And we're not going to get into the specifics of how you treat each type of cancer, because that would be an entire course and an entire career path in and of itself. We're going to focus on sort of the basics, right? And how we utilize medications in order to help manage these patients here. But what you're initially going to see is there's some sort of initiating sort of factor there. The cell gets kind of loses one of those triggers that we mentioned that will sort of inhibit its growth, and then it continues to have this promotion where due to either exposures to certain carcinogens or other sorts of factors there, it'll continue to promote its growth, and then you see this progression where they just continue growing, and eventually what's the concern? So say it's like a nice one localized little tumor. You can see it will metastasize, it will go out to other tissues, and then it will start to grow there as well. Basically just kind of takes over the entire body potentially. And so it's important to know that there's a lot of carcinogens that are out there, and some of them may be medications that we're actually treating our patients with. So similar to what we saw with antiarrhythmics, that any antiarrhythmic can itself cause an arrhythmia, right? Did we talk about that? I believe so. Any anti-cancer drug can also do what? Cause cancer, right? Because a lot of these are going to be carcinogenic, they're mutagenic, they can mutate the DNA, they can be certainly teratogenic, as we'll see, because again, when you think about a pregnant patient, they have a lot of rapidly dividing cells, right? Little fetus growing there. So you see a lot of the drugs we can use, things like alkylating agents, which we'll talk about a little bit later on, anabolic steroids, anything causing or stimulating growth of the body, right? So anabolic steroids like testosterone can stimulate what type of cancer do you think? Type of tissue in the male prostate, right? So prostate cancer can be brought about by exposure to testosterone, right? How about estrogen? What could that cause? Breast cancer, ovarian cancer, right? So a lot of different types of cancers that can be brought about by these sort of growth factors here, right? And of course, there's lots of other ones that we don't have time to really get into, but certainly it's good to know that a lot of the anti-cancer drugs themselves may actually cause cancer. And so here you're going to find that there's a lot of different ability for these cells. They're pretty resistant in a lot of cases, or they develop mutations that make them more resistant. So for instance, they can do things like inducing angiogenesis. What does that mean? Yeah, they can cause new blood vessels to be formed such that they get a better nutrient supply, so they continue growing, right? They become resistant to the medications we use, similar to how our antibiotics become resistant to the bacteria because they develop mutations that make it less effective. Our cancer cells can do the same thing, right? So there's a lot of different reasons why you'll find that these cancers can be pretty difficult to treat there. So getting into our sort of principles of oncology here, one thing you need to know is that a single tumor cell has the potential for unlimited growth, right? So ideally, you'd like to get rid of every single cell that is potentially cancerous, right? Now, is that possible with, say, something like surgery? Like you have a nice, well-localized tumor, you go in and cut it out, you're good to go, right? Yeah, maybe you get really good margins, but still, one tiny cell, is there any way for us to know if that one tiny cell is left over? You can't, right? So this is why you're going to see multiple modalities being used here. Use surgery along with radiation, radiation plus chemotherapy. You're going to see lots of different things here because we got to kill every single cell there, otherwise it has a potential to come back. You're going to find that different tumors will have different growth patterns associated with them, such that they can change based on the stage of disease. So you can have either like really well differentiated versus non-well differentiated cancers here, like say lung cancers versus like colon cancers. Some of them are very slow versus fast growing. So for instance, like leukemia is extremely fast growing because again, your white blood cells are rapidly growing anyway, right? So the cancer is just going to be kind of supercharging that sort of thing. And then talking about whether it's very localized, whereas maybe surgery can be a really good option versus whether it's disseminated, right? Now, again, my exposure is mainly in pediatric cancers because that's where I work and that's what I get a lot of exposure to. And we see a lot of leukemias in that patient population. And so, is surgery a good option for leukemia? Why not? It's everywhere, right? So you can't do that. So this is why we focus a lot on the chemotherapy aspects of it and radiation potentially. And then also looking at the heterogeneity of the tumor. What does that mean? The heterogeneity. Yeah, how many different types of cells are you dealing with? Is just one type that's fairly easier to treat versus you have multiple cell types that may be posing a little bit of a challenge there. So these are a lot of different factors that go into saying like, well, how are we going to treat this? How easy is it going to be to treat? And so there's something called Gompertzian cell growth. And so basically what it says is that every cell has a certain time that it takes to undergo mitosis, right? And so this is why you can have really fast-growing tumors, you can have really slow-growing cancers, depending on what that doubling time is essentially. And so you're going to find that when you're really small, when you have a very small tumor, it has lots of nutrients, it doesn't have a whole lot of other competition around, it grows very, very quickly. Yes, ma'am?
What drives that? Is it the genetic level?
In terms of why it's growing so fast?
Yeah.
Some of it has to do with the type of cell that it is. For instance, like GI cells, they rapidly replicate anyway. So again, they already have that kind of benefit to begin with. But also just matters about tissue supply of nutrients. How good's the blood supply? What other types of cells are around it? Does our immune system have a chance to attack it potentially? So you're going to find that growth fraction will decrease as the tumor size increases. What do you think that is? There's no more room, there's no more nutrients. It kind of will plateau out as you're seeing. I'll show you some graphs here in a moment. And so you'll see that it's initially very rapid, but then it flattens out. And so that would be kind of seen here when you're looking at the actual tumor growth. You see how it's very, very rapid early on when it's small, but as you get, and this is the cell number, or the actual number of cells within that tumor. As it grows, it's going to then flatten out as you start to run out of nutrient supply for those cells there. And you can see how, initially there's a long time where the patient is kind of subclinical, where they have no idea that the cancer is there. By the time you get the diagnosis or they're symptomatic, guess what? There's a lot of cells there we have to deal with. And so you're going to see how our different modalities are actually going to be able to treat that. And you kind of notice here, say for instance, we have the patient undergo surgery to excise that tumor. And again, it'd be nice if we can get rid of every single cell there, but a lot of times you can't. And so then you're going to find this sort of repeated sort of pattern here, the cycling of other modalities in order to try to get rid of those cells. And we'll talk about why you have that cycling as well in just a few moments here. But again, even if you had 99.9% of cells killed right here, you still have a ton of cells that are left around that you have to get rid of, right? Because again, cells are pretty small. So you're going to find that in general, when you're first initially treating these patients, removal of the tumor is obviously going to be the best thing for them. It's going to get rid of the most bang for your buck in terms of getting rid of those cells there. Surgery is good for really well localized, well differentiated tumors. Radiation therapy might be good for localized but maybe difficult to treat or difficult to reach tumors. So say it was like a very deep brain cancer or something like that. But we're going to focus on chemotherapy, right? Because of course it's a pharm class. Now chemotherapy is typically administered systemically, right? And so it's going to be able to kind of get everywhere, but what's that going to lead to? A lot of side effects, right? So, and again, I've never had a particular love for oncology, mainly because I don't like poisoning my patients on purpose, but that's essentially what we're doing, right? So just like we give antibiotics to kill bacteria, we're giving drugs that can kill cancerous cells. And do you think our drugs know the difference between a cancerous cell and a non-cancerous cell? A lot of our old school sort of like gold standard agents, they do not know the difference. And so we're going to see a lot of toxicity. We're basically giving poison to your patients, right? But you're going to see chemotherapy is good for getting all those other cells that maybe you leave behind by radiation or surgery potentially. And so again, this is why we use combination therapy. So again, I can use surgery initially, and then maybe I follow up with several rounds of chemotherapy, right? Now, why do you think I have to stop in between here and give a chance for the cancer cells to grow back? we'll talk about the immune system being a really big thing to take a hit here, but like you have to give the patient a chance to recover, because I can keep giving chemotherapy until all the cancer cells are gone, but guess what else is going to happen? My patient will be dead, right? So that's why you have to give the body a chance to recover, allow the healthy cells to recover. You know the cancer cells are going to grow too to some degree, but that's okay. You're going to hit them with another round of chemotherapy, hit them another round, until hopefully you get rid of all the cancer cells and you have a healthy patient left behind, right? So we're going to find that when we're doing administering chemotherapy, the drug concentration, the exposure time, the frequency of administration is really critical for its effectiveness, so how well our drugs are going to be working. And so we know these drugs are toxic, and so we really have to try to dose them such that we're going to be maximizing the benefit of getting rid of cancerous cells while also helping to mitigate the risk and trying to keep our healthy cells alive as much as possible. And we're going to see there's a lot of significant toxicities. And so what you tend to find is that the most rapidly dividing cells tend to take the biggest hit when giving chemotherapy, which makes sense because cancer is just a bunch of rapidly dividing cells anyway, right? So again, they're going to be affecting those. So when I say rapidly dividing cells, where are some cell lines are going to get hit most? The bone marrow, right? So you're going to see myelosuppression, which can lead to what? Infection, right? It's oftentimes it's not the chemotherapy that kills these patients with the cancer, it's the infections they get as a side effect of the drugs, right? What else? You mentioned the hair. Alopecia is a common side effect, right? Because our hair cells are rapidly growing, right? Some of us may be having slower and slower rapidly dividing hair cells, but in general, that's why alopecia can be a common side effect, right? What else? Yeah, the GI tract is going to be taking a big hit as well. You can see things like stomatitis, where actually those mucosal cells will not be replicating appropriately. It's ulcers in the mouth and can make it very difficult for them to consume enough fluids and food in order to maintain their nutrition, right? So you see a lot of side effects related to the effects of these drugs here. So typically what we shoot for is that when we're administering this, we go high dose with intermittent scheduling, meaning say for instance with your beta blocker, you take that every single day, right? This is going to be something where I'm going to hit them with a big dose, try to hit as many of those cancer cells as possible, knock them down, and then I give the body time to recover. And then I hit them again with the chemotherapy, and then I give the body time to recover. And I'll show you a roadmap here in a little bit of how we would actually cycle these medications here to give the body a chance to recover there. And then the other thing here to consider as well is where's the time for maximum susceptibility? So depending on the mechanism of the drug, it's going to work in different parts of the cell cycle. You guys remember your cell cycle? Remember, like the S phase is used for what? Synthesis of DNA, very good. How about like the M phase? That's where the actual cell division actually occurs, mitosis. So we'll talk about that briefly and see where these different drugs are working at. And so you're going to find that depending on where the cells are at in terms of their growth phase, and especially if you're hitting them when they're in that very early part of that curve, you're more likely to see a lot of them rapidly dividing. Because if you hit them at the plateau part of it, a lot of them may not be actively undergoing growth, and the cancer drugs are not going to work too well. Versus if you excise that tumor and leave back, say several thousand cells, they're all going to be actively growing. Our drugs are going to work that much better. And that'll make sense when we get into the actual mechanisms. So I'm sure most of you have seen this at some point in your undergrad biology perhaps, right? Or maybe in your physiology, but seeing here how a lot of cells are going to be in this G0 phase, right? What's happening in G0? Anyone know? Cell's just kind of doing its thing. It's just kind of going about its day, not really actively undergoing any sort of growth or mitosis, right? But we're going to be focusing more on these rapidly dividing cells because all of your cancer cells should be in this cycle somewhere, right? So you're going to find here that things like the S phase, certain drugs are going to work on DNA synthesis specifically, and that will be inhibited. If you cannot produce new DNA, what happens to that cell? It's going to die off, right? It's going to trigger our apoptosis once it realizes, hey, there's a lot of damage done to the cell here. It's not really viable any further, right? We're going to see here in the G1, G2 phases, certain drugs are going to work a little bit better here. Certain drugs will work well in the mitosis phase. And we'll cover each of these classes of drugs as we get into it, right? So kind of this is a good table to refer back to see where the drugs are working. And some of that should be pretty intuitive when you understand the mechanisms. So as I mentioned, the cell cycle, mitosis is going to be a very important target, actually preventing that cell division from occurring in the first place. And then also the S phase is going to be another big part of it. Now, those drugs that only affect certain parts of the cell cycle, we call cell cycle specific drugs. Some drugs are non-cell cycle specific. We'll talk about the difference there. You can kind of give them at any point, and they're just going to work pretty well regardless. We'll get into those delineations in just a little bit. Okay, so when we talk about cell kinetic parameters, we talk about things like growth fraction. So if they're early on in that curve, there's a very high growth fraction because most of the cells are replicating. If you get them at the top of that curve where it plateaus out, maybe your growth fraction is diminished there. We also talk about things like S fraction, which is the percentage of cells that are going to be actively dividing their DNA. And then we talk about the doubling time and how long it takes for those cells to actually replicate, right? Shorter doubling time typically means the tumor is rapidly growing, it's more aggressive. Okay? So looking at how we actually are going to dose our drugs here, so typically we like to use combination therapy. One, that's going to try to minimize resistance to our actual chemotherapy drugs. So as you cause mutations in these cells, you can cause resistance to occur there. And so by using combo therapy, you can help to mitigate that to some degree. And by using combinations of drugs here, you can hopefully try to use lower doses of each in order to help minimize some of the side effects, as we'll see, because that's going to be one of the biggest things to handling these patients is managing their side effects. Okay. And then we'll look at adjuvant therapy. When I say adjuvant, what does that mean? Kind of supportive medications, things that are going to kind of help the patient along. Even though they don't directly treat the cancer, they still are very necessary and very important to include in their regimens to make sure they're being managed appropriately. So for instance, someone mentioned nausea, vomiting being a major side effect of a lot of chemotherapy drugs. Does anyone here like to throw up? No, it's pretty miserable, right? And so these patients, unfortunately, are given drugs that sometimes they even get what they call anticipatory vomiting. So if you ever had like a really bad like lunch or something, and like that certain food just made you sick to your stomach, and anytime you even look at that food, you get sick to your stomach again. Anyone ever had that? Yeah, probably. Or certain people you get around, you just get sick to your stomach as soon as you see them, or certain classes. Well, the same thing can happen for these patients where they're going in to get their chemotherapy and they remember how sick they felt, and they get sick again just feeling that way. And so there's a lot of different drugs that we can incorporate in order to help manage that, as we'll see in a little bit. Even things like drugs to stimulate bone marrow growth, right? Because we know myelosuppression is going to be one of the most dangerous things these patients will experience. Maybe we can give them things that help stimulate their bone marrow to come back, right? But what if it was a leukemia that they had? Maybe it's not a great idea because those could be cancer cells you're stimulating as well. So we'll look at some different factors there. So as I mentioned, in terms of timing of the chemotherapy, we'll look at drugs that are both cell cycle specific and non-specific, meaning some of them are only going to work in certain phases of the cell reproduction cycle. Some of them are going to be non-dependent, and you can kind of give them whenever. And so you'll see that difference a little bit in some of these regimens here. And as I mentioned, we give them in cycles. You have to give them big doses up front, kind of get the cancer cells knocked down as best you can, and then you give the patient time to recover, and then you hit them again, okay? Now, how we determine this a lot of times is based on clinical trials, right? So this is where you're going to find that a lot of patients you deal with, especially in pediatrics, we have what we call the Children's Oncology Group, or COG. A lot of our patients get enrolled into these clinical trials because we need to find out what's the best way to manage these patients here. And so it may be they get one type of dosing regimen versus another. You know, we would never do placebo versus chemotherapy. Why would we not do that? Not very ethical to let your patient's cancer continue to grow. So you got to give them something, but you can at least make comparisons between different regimens, maybe the gold standard versus a new regimen you want to try out to see how it works for them. So a lot of them tend to be on clinical trials in order to see kind of what the best way to treat the patients are. So here's an example of a roadmap. This is actually one that we use pretty frequently over at Nemours. And so when I say roadmap, that basically means these are all the drugs you're going to be taking, and here's the schedule on how they're actually going to be taking it. And so I want to kind of point out a few things here that will become important as we kind of go forward. So for instance here, there's different phases of treatment. There's things like induction and consolidation and things like that. This is for ALL patients, right? Very common regimen we would give to our patients here. And so basically, you're going to see here's the different list of drugs these patients will be receiving, right? When you see, and just like with HIV treatment, you're going to find that oncology, they love their acronyms. And so you'll see a lot of acronyms there. I'm not going to have you memorize those for the test, but I may just kind of put them on the slides just so you can have some exposure to it. But I'm not going to put like Ara-C on a test question and expect you to know that that's cytarabine, right? Or CPM, cyclophosphamide, things like that. Some of the abbreviations are intuitive. Some of them have no relationship whatsoever to the drug itself. But anyway, so we can see here different drugs the patients are going to be receiving. What do you notice about the routes here? What's IT mean? Intrathecal, right? So sometimes we can actually administer this through, they'll actually do a lumbar puncture and administer this intrathecally in order to get those cells that are growing within the cerebral spinal fluid, right? Why would we have to give that directly? it's really hard to cross that blood-brain barrier in a lot of cases there, right? So we have to be able to get more direct and actually give that there within the CNS. You're going to see that a lot of times the dosing is, how do we do the dosing here? What's that M squared mean? The body surface area, right? So we'll figure out what the body surface area is for the patient that takes into account both their height and their weight, and then come up with their dose there, right? It's a very exact sort of dosing, much more precise than you would see with, say, something like giving hypertensive medication to a patient, right? We do this because this is very high-risk medications or very toxic medications, so you want to be very precise with how you're actually administering it to those patients there. So just to give you, yeah.
For adults as well, like that?
Yeah, you may see that for adults as well. Some of them maybe have more kind of like standardized dosing, but we do this all the time for pediatrics. It's kind of our standard there. But, and again, like I said, I've only done pediatric oncology. I don't have a particular love for the topic, but it's what I get to do with my day job. We do it pretty frequently. Anyway, so you're going to also like look at the observations here. What are the things you're going to monitor in the patient? So for instance, why do you think weight's so important to monitor here? Yeah, they could be losing weight because they're not having good PO intake from the drugs, or having nausea, vomiting, so maybe they don't want to eat. Also, they're pediatric, so they grow pretty rapidly, so that could be changing and may adjust the dose you actually have to give your patient. Why do you think we look at the CBC? So blood cells are going to be inhibited, right? So you're looking at your white blood cell count. You're looking at your platelet count. Thrombocytopenia can be a common side effect here, right? Also, when you're looking at it with the diff, what's the big cell line you're looking for in terms of white blood cells? The neutrophil count. So we'll frequently look at what we call the absolute neutrophil count to make sure that they are okay to receive chemotherapy. If they, for certain regimens, if they are too low on their platelets or their neutrophil count's too low, they're too big a risk to receive any further chemotherapy because that would just lower them further. And so we just go ahead and wait until they actually make counts. So if you ever hear count dependent, that's what they're referring to, is they want to make sure their neutrophil count's good and their platelet count is good. So other things you can look at, depending on the drugs, you may be looking at liver function, you may be looking at other things like that. And so looking at the actual regimen itself, you can see here that it's based off of the day that the patient's actually on and which drugs they're getting here. So for instance, cyclophosphamide, they only get one big dose right up front. We're going to learn that's a cell cycle non-specific drug. It's a very good drug, but it's very toxic, so they just get one big dose up front, and then they don't really receive it for another period of time. Versus, say, something like Ara-C, they get for 4 days in a row, and then they come back 4 days later and get another 4 days in a row of that drug, okay? Versus mercaptopurine, they're getting every single day. So you'll see the drugs are being used in different regimens there, but they're working synergistically together to get better kill on those cancerous cells there, okay? For instance, like IT methotrexate, they're only getting on day 1, and they get on day 8, and they get it on day 15, 22. So there's a very regimented sort of approach to how these patients will get their drugs, and so it's very specific to that particular type of cancer and for that patient there. Okay. Any questions on that? You'll see it's pretty commonly if you deal with any kind of, especially with pediatric cancers, we always are looking to do our roadmaps. We also want to make sure that patients are getting signed off, make sure that they actually got those doses, so that way we know that we're on the right track there. Yeah, it depends. Sometimes we'll do one at a time. So for instance, in this kind of regimen here, we'd hit them with a cyclophosphamide, say hour 0, like at the very start of it, and maybe that runs over, here you're going to see, runs over 30 to 60 minutes, and then after that drug, we would then start the cytarabine. And you can see here that's actually being given over, say 1 to 30 minutes, depending on how you're administering. So you hit them with one, hit them with the next one. Some of the daily meds they can kind of take whenever, but it just depends on the situation.
Is this the antibody dose above and actual dose administered? Does that vary then? Where they might give the full calculation?
Sometimes it can depend. So for instance, sometimes we have regimens where they have escalating doses. And so for instance, we do like a lot of escalating methotrexates, where maybe they start off at 50 milligrams per meter square for the first dose, then you get 100, 150, 200, and they'll actually escalate as they go along, depending on if their blood counts are looking good and all of that. Sometimes there could be variations, so the oncologist may decide that, hey, they're experiencing one type of toxicity, they want to lower the dose, right? So that would be things that would be notated here on the regimen. And again, if you think about the normal checks and balances, say for instance you're in the hospital and you write an order for a beta blocker, okay? I don't know why I keep doing beta blockers as my examples. Let's say you write an order for a beta blocker. You write that order, it gets transmitted to the pharmacy, a pharmacist verifies it, and then it gets sent over to the nursing unit. The nurse gets it, and they give it to the patient, right? So a couple of checks and balances along the way, but it's fairly straightforward. When you're doing oncology stuff, and this is just how we do it, I imagine it's pretty similar in other places as well, there is the oncologist that first signs orders. Usually the nurse practitioner or PA, whoever they're working with, will sign the second set of orders. So there's a double signature on that orders. 2 pharmacists check it off. So we'll do like a first check and then a second check. So 2 different pharmacists will do that. And then when it gets over to the nurses, they have 2 nursing checks, right? So it just goes to show you we have a lot of double checks in place here, because you could really harm someone if you give this incorrectly, the wrong dose, wrong drug, anything like that can be really problematic. Some of these drugs, if they're given via the wrong route, it can be fatal, right? So you gotta be really careful with these agents here, as we'll see as we go forward. Any other questions on that? Okay, yes ma'am.
Isn't there a board that decides what type of chemos or patients get?
Yeah, sometimes you'll see there's like, I'm trying to think of the name they have. Sometimes they have like tumor rounds, or they have like oncology rounds, or they may have, especially like difficult to treat patients, they may have cases where they actually bring in multiple clinicians together in order to kind of come up with a treatment plan that's best for that patient there. So sometimes they'll have either difficult to treat cases or special cases that will kind of come up for a review. Some of these are just kind of routine, and they may not undergo such scrutiny there. But yeah, they certainly have had that before. Because again, it's not just the chemotherapy they're getting. Depending on the type of cancer, you're also talking about surgery. So you're meeting with surgeons. You're also meeting with other ancillary staff. And again, interdisciplinary care is extremely important, just like with other aspects of medicine, certainly in oncology, right? You gotta get your pharmacist on board, your nutrition on board. You got to get, the social workers on board. Because again, this is a chronic disease that they're going to be dealing with for a while. You got to make sure everything is set up. I mean, some of these kids are coming in sometimes 2-3 times a week, and so how do they get transport there? How do their parents, they are able to take time off to come and actually make that happen? Do they need at-home care? There's a ton of stuff that goes into it, so yeah, it gets very, very complicated. Okay, so there's some other types of therapies. So we mentioned that our cancer drugs are not super specific for just cancerous cells. They'll affect our normal healthy cells as well, which leads to a lot of those toxicities. And I'm not going to get really in depth on this because it's kind of a newer field, and it is going to be something that is rapidly sort of exploding here. But there's other types of targeted therapy. So sometimes with certain types of cancers, they may be presenting a certain type of receptor, or they may have a certain type of protein that they express that no other normal cell would normally express. And so if we can target that specifically, we can actually have much more specific therapy and actually treat that one particular type of cancer. So sometimes for certain types of leukemias or other types of, say, for instance, like breast cancers, we can actually genotype those cells and actually figure out what type of special proteins that they're expressing and target those very specifically. And so we can actually have specific antibodies sometimes that will go in and target a specific, say, growth factor. And if you can inhibit that only that cancer cell produces, guess what? You inhibit mitosis of all those cancer cells potentially. What do you think that does to the toxicity profile of those drugs? Because they're so specific, they actually go down quite significantly. So they're much better tolerated, but unfortunately, if you don't have that one particular type of cancer, that one variant of, say, breast cancer, then you're not a good candidate for it. So it's very patient-specific in those cases there. We also have other things like biologics, so we have different growth factors we can administer, sometimes vaccines. Certain vaccines can prevent cancers. Anyone know any examples of that? Gardasil is a really good one. So it's against HPV, that can prevent what types of cancers? Cervical cancer, anal cancer, several different types there. What else do we have? How about for hepatitis, right? Hepatitis can lead to liver cancer, and so we can block Hep A and Hep B, and so that can be beneficial there as well. So there's, vaccines can come into play here. Monoclonal antibodies, again, they can be very specific in targeting certain receptor types, and again, that will help to mitigate a lot of those toxicities while still being pretty effective at killing off those cells. Not only that, but we have our own host immune system that can help us out. So sometimes we'll give drugs that stimulate the host immune system in order to attack those cancerous cells. So it could be another route as well. Again, those are kind of blowing up, so I'm not going to get super in depth on all of those drugs. We're going to talk about sort of our gold standard chemotherapy, because those are going to be the things you run into sort of most commonly. Is anyone interested in going into oncology? Yeah. However, are all of you going to see patients with cancer, most likely? Probably, right? If you're working in the ER, even if you don't deal with patients and actually give them chemotherapy, you might have patients who are on chemotherapy. So you still need to have exposure to it. You still need to know what the common side effects are, so that if you have a patient who's on active chemotherapy and they come in with a fever, you should be really have infection high on your differential, right? And because again, they may not be manifesting a lot of other signs and symptoms of infection because their immune system is so knocked down. And sometimes fever is the only thing they present with. And so we'll talk about febrile neutropenia and things like that. But again, you're going to be dealing with these patients regardless of if you work in oncology specifically or not. But then getting into education, obviously, is going to be very important in terms of making sure patients are compliant with their medications, especially if they're taking things at home, making sure they come to their appointments, making sure they understand the side effects that can occur here, things they should be expecting, things that are, you know, kind of warning signs they need to come into the ER for. So education is super, super important for those patients. And then, again, looking at our toxicities, I'll focus a lot on this. You're going to see that because we're killing rapidly dividing cells, we've already alluded to this, that things like the bone marrow is going to be affected. So you can see things like thrombocytopenia, neutropenia that can happen with this. The GI tract is going to be affected. Hair is going to be affected. Also, the reproductive cells are going to be affected as well. So again, sperm production is going to go down. Menstrual irregularity is going to occur here. So again, a lot of side effects of these medications. Okay. So, any questions on that so far before we get into the actual drugs themselves? Okay, so getting into it, and again, this is not an exhaustive list, even though you may feel exhausted after we get through them. And the main point is not to make sure you know which drugs are used for which type of cancer. I will mention some of those, just in how we actually use them, but I'm not going to ask you on a test which one of these is good for ALL. That's not really our scope here, right? It's kind of outside of our scope. It's too big of a topic here. What I am going to focus on are the mechanism of action of the drugs. I'm going to focus on the side effects, especially if there's any unique side effects to the drugs, any drug interactions that could be particularly important. If there's an antidote to a chemotherapy agent, you want to know that, right? How we can actually help to support these patients with antidotal therapy. Anything like that. Those are kind of the key things I want you to take away when we go through this list here, okay? Okay, and you can see, especially when we're talking about where the actual drugs are working, this is a good picture to go back to and kind of review this, so you can see kind of where drugs are working in terms of affecting DNA synthesis, where they're actually working directly within the DNA to cause inhibition, how they can affect RNA, protein synthesis. We'll kind of go through all of these and kind of see how they work more specifically, okay? So the first group we're going to talk about is what we call our anti-metabolites, and so a lot of these actually look very similar to our normal nucleotides that make up our DNA and RNA. And so we'll look at ones that look like pyrimidines, we'll look at ones that look like purines. And basically what happens with these drugs here is that the body can't tell the difference between the drug and what a normal nucleotide that they want to incorporate into their DNA or RNA would normally be, okay? So what happens there is that we'll have the drug gets incorporated into the DNA, but it normally will lack things like a sugar backbone, or it will have some sort of change modified to it, such that the cell can no longer produce any more DNA on there. It can't add any other nucleotides to it. And so what we call those is we call that a chain terminator. And these are actually very similar in actions to some of the antiviral drugs we've looked at before. So if you think about acyclovir or valacyclovir, they work very similar to this, to the antimetabolites. And so you're going to find that, again, they're not going to be very selective for just cancerous cells. But you might see, like, what phase of the cell cycle do you think these are going to be working best on? Probably the S phase, right? Because that's when you're actually producing new DNA, right? Maybe affecting other phases as well in terms of RNA synthesis, but we're going to focus on the DNA synthesis. There's three groups we're going to look at here, including the pyrimidine analogs, purine analogs, and then our folate antagonists, okay? So starting with our pyrimidine analogs, we're going to see cytarabine's a good one to start with, sometimes called Ara-C, if you ever see that. And basically, if you were to look at a normal cytidine, what this looks like, or deoxycytidine, which would get incorporated into the DNA, what do you kind of notice here about in terms of the modifications to the cell? So here's the Ara-C, the actual chemotherapy drug. They really just add on a hydroxyl group there, and that's enough to cause no further nucleotides be added onto that, and thus that can arrest further DNA replication. So even very simple changes to the molecule can cause big changes in terms of its cell's ability to produce new DNA there, right? And again, I'm not going to expect you to draw this on the test or anything like that, so don't worry too much. I'm just using it as an example to show you kind of how we're actually causing these changes to occur. So cytarabine, Ara-C, is going to be a cytidine analog. As I mentioned, it gets phosphorylated, gets incorporated into the DNA, but then it's going to disrupt that strand elongations. You can't produce any further, add any more nucleotides to that. That's a chain terminating sort of effect there. And we oftentimes, and again, I'm not going to ask you specifically about routes of administration, just again using this as an example. You can either give it intravenously, give it intrathecally, in order to, depending on where those cancer cells are that you actually need to treat. And so I use it a lot. I mean, this is probably one of the more frequent ones I end up using for a lot of pediatric cancers, a lot of leukemias. Because again, what do you think about the S fraction, say, in a leukemia patient? It's probably pretty high, right? Because again, it's a rapidly dividing tumor or rapidly dividing cancer. You're going to be seeing that a lot of those cells are in that S phase, so this drug would work pretty well for that, right? And so again, getting into toxicity, these are really big points you want to know about as well, okay? Now again, I can say nausea, vomiting, and that's going to be common with any of these drugs here. Now certainly we'll talk about emetogenicity. It's a very fancy word for saying how likely it is to make you throw up. Like my emetogenicity scale of my classes are usually like an 8. Right around test time it goes up to about an 11. But point being is that some drugs are going to have high emetogenic potential, some that have relatively moderate to low emetogenic potential. But certainly when you start adding drugs together, guess what? You're going to see a lot more synergy there. So you can see nausea, vomiting, you can see mucositis, right? So you can see those mucosal cells within the mouth and the throat are going to be inhibited such that you get those ulcers that can form there. And then interestingly, and again, you want to kind of focus in on sort of unique side effects of the drug. So those are good questions I could ask potentially on a test, or they may come up on your boards potentially. With ARC, you can actually get what we call a cerebellar syndrome, where you can actually end up developing things like dysarthria, which I'm developing a little bit of right now, nystagmus, ataxia, and again, this may be more likely to be seen in patients with like renal dysfunction. So they can't clear the drug very well, they're going to hold on to more of it. You can end up developing these CNS side effects there. Also, you can end up seeing things like conjunctivitis. So in those patients there, and occasionally we'll just give them saline drop substitutes, like an artificial tear sort of substitute, or in some cases it could be so severe that we actually have to give them steroids in order to help decrease some of the inflammation, and actually allow for normal tear production to occur. Now, normally do we like to give patients steroid eye drops? Not typically, right? Remember, there's a lot of side effects associated with that, corneal thinning, glaucoma, there's a lot of problems with it, but it could be an option there if they're having really severe dry eye associated with cytarabine. Sort of similar to that, we have gemcitabine. Again, it works similar to cytarabine in terms of its mechanism here, but what do you notice about the structure? Add 2 fluorine molecules onto that instead, right? And again, we don't normally see that in DNA, so that again will inhibit further strand elongation of those points there. So again, very similar toxicities. In some of these patients, you may develop what we call like a flu-like syndrome, where basically they can develop myalgias, a low-grade fever associated with this. And again, anytime a patient on chemotherapy gets a fever, you want to be cognizant and think about infection. But here, it's actually just a sort of a side effect of the drug. Normally, we can just treat with acetaminophen. That's generally pretty good for those patients. Now, one thing you have to be careful of is using NSAIDs in patients who are receiving chemotherapy. Now, why would I care about that? So maybe it could affect the stomach potentially, but more likely, we're talking about our blood cells. What effect do NSAIDs have on any of your blood cells? They thin the blood a little bit, but how do they do that? It's good to know for your test because we just talked about antiplatelet drugs, right? Just like aspirin has antiplatelet activity because it does what? Blocks cyclooxygenase, right? So if you have a patient who's thrombocytopenic, you don't want to give them any NSAIDs because that could increase their bleeding risk, right? Those platelets that are there, they're already in low numbers, but if you inhibit them any further, you can see bleeding as a risk there, right? So again, be cognizant of that. If you have a patient who comes in with fever and they're on active chemotherapy, don't just give them an NSAID. Check their CBC first, see what their platelets are looking like. If they're good, then you may be okay. Otherwise, hold off on it. Give them acetaminophen, and you're generally going to be a lot safer from that standpoint, okay? So again, little things you have to think about as a side effect of the medications you're giving there. With our pyrimidine analogs, we have things like fluorouracil and capecitabine. Capecitabine actually gets converted into fluorouracil, and I love the abbreviation for fluorouracil. I was like, hey, 5FU, buddy. I don't know why they call it that, but anyway, that's basically how the drug abbreviation comes up. But this is a false pyrimidine, right? So basically what it does, it actually gets incorporated in part of the actual production cycle of some of your nucleotides, and by inhibiting this thymidylate synthetase, you eventually inhibit the actual production of thymidine. And so what you can find there is instead of getting incorporated into the DNA and preventing further elongation, this is another way we can sort of interrupt the process here and prevent production of new pyrimidines by inhibiting this enzyme thymidylate synthetase here, right? To some degree, it can also get incorporated into RNA and inhibit some function there, so that can actually deal with more like actual cell function and protein production there. And again, we use this a lot in different types of leukemias potentially. So again, you're going to see dose-limiting leukopenia, meaning if you have your neutrophil count that's too low, your risk for infection gets too high, and thus we may want to hold off. We want to give the patient more time to recover before we give them more chemotherapy. Again, you can see that cerebellar syndrome, like you mentioned before. And one thing is unique to some of these chemotherapy agents is what they call a hand-foot syndrome. Anyone know what that means?
Dactylitis.
Hmm?
Dactylitis.
Say it again?
Dactylitis.
Not necessarily. This is more like it's a neuropathic sort of pain that occurs, and it really occurs in like sort of the most distal neurons, and so typically like the hands and the feet get most affected by this, and so they can develop paresthesias, they can develop neuropathies. It can be painful sometimes. Sometimes it can feel very kind of hot, tingly sort of neuropathic pain there, and so that is one thing that may limit us from giving any further drugs. We'll see a few drugs that have that sort of hand-foot syndrome or like a stocking glove syndrome, they may also call it, sort of distribution there. And again, mention the conjunctivitis. Yes.
The mechanism, do you just want us to know that they inhibit DNA synthesis, or do you want us to know that they create T cells?
No.
To be like inhibiting alkaloids?
I mean, at a base, you should know that it's inhibiting DNA synthesis, but, you know, am I going to get into a semantics argument on a test question where I'm trying to differentiate the action between, say, cytarabine versus 5-FU? Probably not, right? I'm more focused on, you know, the big difference is like, is this an alkylating agent versus an anti-metabolite versus, now some of these, like, especially when I get into like the next drug, methotrexate, that's fairly different in terms of its actions, and so that one, that'll be clear in a second, the differentiation there. But yeah.
Why would you ever give cat? It's just in terms of
Some of it has to do with it being like orally bioavailable, so like it's a prodrug sort of. So if I can give that sort of like chronically, they can take that orally and gets converted into 5-FU. They can have better actions there. So it just depends on the regimen that they're giving. Yeah, capecitabine I haven't seen too much use, and fluorouracil probably I've seen maybe 4 or 5 times and that I've been over at Nemours, but again, I'm only there 1 day a week nowadays, so I don't see it all the time. Cytarabine I see much more utilization of, but again, depends on the cancer type that you're dealing with. So next up we have a few purine analogs, and so for instance we have 6-mercaptopurine or 6-MP, and you have things like thiaguanine. Again, this is another commonly set of drugs we end up using for for leukemias and things like that. If you notice, if you look back on that roadmap, you're using both cytarabine and 6-mercaptopurine. Does that make sense? Use both of those together. They're both antimetabolites. But it does, because if you imagine you're using both a purine and a pyrimidine analog, you're kind of attacking from different aspects there. You can affect both purines and pyrimidine synthesis there. And so you'll find the mechanism is actually going to be very similar here. It actually prevents the purine synthesis, things like adenine and guanine, but it also gets incorporated into that DNA and actually can inhibit DNA polymerase from working any further. So you're kind of hitting it from both sides there, both the ACs, Ts, and Gs, they all are going to end up getting affected there, right? Now these ones you're going to see hepatotoxicity, myelosuppression are pretty common with a set of drugs here. And also you can actually see in some cases we'll do pharmacogenetic testing beforehand to see how they're actually going to clear the drug to make sure that they won't have any worsened toxicity, right? So sometimes we'll do pharmacogenetic testing beforehand, see how they're going to process it effectively. And it may incorporate dose adjustments based off of that. Now, folate antagonists, or methotrexate, sort of a unique drug. We're going to see this come up a lot in terms of rheumatoid arthritis and other autoimmune diseases. So this will come up in things like, inflammatory bowel disease, comes up in rheumatoid arthritis, lots of different disease states. Because again, if you think about autoimmune diseases, it's a disease of inflammation. So I can give things that inhibit inflammation, inhibit, say, the immune system, and that's going to be very effective, right? So we can do the same thing here for these leukemias by giving these drugs. Are going to help to inhibit its growth and suppress it. Now, if you had to imagine, say, something like cancer, like a leukemia versus, say, an autoimmune disease like rheumatoid arthritis, which one do you think we get a bigger doses of a drug like methotrexate? Just intuitively, what do you think? Probably cancer get the bigger doses, right? I'm trying to wipe out all of those cells, right? For something like rheumatoid arthritis, I'm giving lower doses because I only want sort of a decrease in activity, but I don't want to wipe out the entire immune system. So sometimes the degree of myelosuppression can be different depending on the dose you're receiving here, right? So for instance, for rheumatoid arthritis, maybe I'm giving 25, 50 milligrams of methotrexate a day. For some of these patients on these regimens here, I may be giving grams of methotrexate in order to try to knock out all of those cancerous cells, right? So again, it all has to do with the dose in some of these cases here. But anyway, we have methotrexate. Again, you're going to see this used in a lot of rheumatologic conditions, as I mentioned. Basically, what it does is it inhibits dihydrofolate reductase. And so this is an important enzyme here. You can see where it's working here to inhibit eventual synthesis of some of these pyrimidines there, right? So you inhibit dihydrofolate reductase, you reduce these tetrahydrofolate stores, and thus you're going to get less purine synthesis occurring, less DNA, RNA production. Thus it tends to be pretty effective for suppressing the immune system, right? And we use it orally. Sometimes we use it every single day orally. We'll give it in IVs or really big doses, depending on the regimen, or intrathecally is another common one we'll do there. And so what you can end up seeing is there's a lot of side effects associated with this drug, and so which is why it's important to know how to manage those sort of things there. So certainly GI toxicity, myelosuppression, hepatic function can be an issue there. But also think about like renal function, right? So this is an interesting thing where actually methotrexate can cause interstitial damage to the kidneys themselves, basically because the drug itself can actually precipitate out into the renal tubules, and when it does that, it can actually cause damage to the cells directly. And so this is another big thing we want to watch for, is making sure that the patient's well hydrated. So oftentimes if they're getting really big doses of methotrexate, we'll actually give them a lot of fluid to make sure that the kidneys are nice and well perfused and they're producing very dilute urine, right? How can you check to see how dilute the urine is? With like specific gravity on the UA, right? So you can sometimes we'll actually wait and not give certain chemotherapy agents until we see the specific gravity gets low enough to know that, okay, yes, we do have a dilute urine that we're actually dealing with there. Anyway, you also see methotrexate really highly protein bound to albumin, so that can have interactions where some other drug can kick methotrexate off, or methotrexate can kick another drug off of albumin, can cause increased effects of those drugs there. Now, things that we'll give in order to help decrease the toxicities of methotrexate, right? We haven't really covered any antidotes yet. This will be the first set. For one here, you're going to see that, as you might imagine, a lot of your cells may develop folic acid deficiencies because they can't really process it effectively due to the methotrexate. So, kind of blood dyscrasias could you see there? Mentioned myelosuppression, but what else can you see? Maybe become like anemic, right? So again, you can see that as a common side effect. So what we'll do for these patients, I could give folic acid, but it's not really going to do them any good because the cells can't use folic acid because that dihydrofolate reductase is being inhibited. So what I can do is give the activated form of folic acid, otherwise known as folinic acid. Okay. Another name for this is leucovorin. And so we can give this, and essentially what we can do is what we call a leucovorin rescue, where we will give a really big dose of methotrexate up front, really kind of drive down those cancer cells as best we can. We know we're affecting healthy cells as well, but then once we give it a period of time, we wait a period of time, we can actually then give them leucovorin to try to help save those healthy cells as best we can, right? So again, it's a way to help kind of recover those cells, hopefully limit some of the other side effects, things like the myelosuppression, things like liver toxicity, things like that. And so oftentimes we may actually be giving leucovorin until they get down to certain methotrexate levels until they kind of clear the drug, and then we can stop the leucovorin. But that's kind of the main antidote we would end up giving for that. I've had patients from the poison center side of things that were taking methotrexate for like rheumatoid arthritis, and they took too much. We actually give them folinic acid for the same thing to try to help kind of maintain those cells as best we can. Another thing we can do to help mitigate some of the renal toxicity of methotrexate is actually give them sodium bicarb. Okay. Now, sodium bicarb does what to the pH of the blood in the urine? It should increase it, right? So what you find is that when you have more alkaline urine, that tends to increase the solubility of methotrexate, and that prevents it from precipitating out. So if I'm giving, say, grams and grams of methotrexate, frequently we'll give them fluids that also contain sodium bicarb, and that will actually help them to alkalize the urine and keep it from precipitating out, thus they don't develop renal toxicity. Okay? Sodium bicarb alkalizes the urine, makes it more soluble. Okay, and then if all else fails, we also have a drug called glucarpidase. This is actually an enzyme, synthetic enzyme that we produce that actually goes and metabolizes the methotrexate directly. And so we use this exceedingly rarely because it's actually quite expensive. I think it's in the range of like $100,000 for a single dose in order to actually get rid of the drug entirely. And so we would use that for patients maybe who develop renal failure while they're on the drug and they can't clear it. If they maybe had an intentional overdose, something like that. Those would be the case we'd actually give it, but again, exceedingly rarely we do that. Still good to know about. Okay, so those are kind of the three drugs we would give in terms of antidotes, so to speak, or to help mitigate some of the toxicities of methotrexate. Okay. Any questions on that so far? So those are all the antimetabolites we've kind of covered. So pyrimidine, purine analogs, and then also the folic acid antagonists.
Would you give the folinic acid and the bicarb together, or not necessarily?
Yeah, so for instance, we just had a patient we were dealing with, they're getting high dose methotrexate. So I think they were getting like, 25 grams per meter squared of methotrexate. So it was just like pretty huge dose. I think it was like, as I mentioned, like, patients for rheumatoid arthritis maybe getting like 25, 50 milligrams a day. This patient was getting like, I don't know, 30 grams or something. So milligrams to grams, right? So a huge amount of methotrexate. So what we did first was we actually started them on prehydration. So you actually give them a lot of fluids. So you're giving them a ton of fluids IV that includes sodium bicarb. to alkalize the urine, so that way when they start to get the methotrexate, whatever does hit the kidneys gets cleared out, no problem. And then afterwards, it was actually set up to where you give them the methotrexate, it would run over, say, 4 hours, and then, say, 24 hours later, you start the leucovorin. Right, so you give the methotrexate time to kill off all those cancer cells as best they can, and then 24 hours later you start the leucovorin and you administer that until the methotrexate levels are actually low enough to where it's, say, below a certain threshold, and then you stop it altogether. So there's just one way to do it. There may be other cases there. We'd actually, I'm sure there's other regimens out there, right? Because again, they're kind of doing two different things. Bicarbs in order to help mitigate renal toxicity, the leucovorins in order to help kind of salvage all the other healthy cells, GI cells, bone marrow cells, all those things there, okay? Any other questions so far? If not, let's do a 10-minute break and we'll come back and finish up the section. I didn't see any questions up on the board. Any questions from you guys here in person? Nothing at all. We'll continue on. So, okay, we had our anti-metabolites. Now we're going to have microtubule targeting drugs. If you had to guess where this works in the cell cycle, what do you think? It works on the microtubule. Where in the cell cycle? Where in the part of that growth phase? Where are microtubules really, really important? The M phase, the mitosis phase, right? Remember when you think about mitosis, you get to the point where all the chromosomes, like, they line up right along the center of the cell and they get yanked apart by the microtubules. That's where we're going to be affecting this. I'll show you some pictures here in just a moment. But basically, other things that microtubules are really helpful for is actually maintaining that cytoskeleton within the cell. It's kind of what provides that scaffolding that gives the cell its structure there. But yeah, they help separate those chromosomes during mitosis. And so if you arrest that process, the cell can't undergo mitosis, and eventually it gets the signal, hey, we just need to kill off this cell here. It's not working anymore. And so you're going to see that there's two main groups of drugs that we use in terms of chemotherapy. We have the Taxanes, and then we're going to have the Vinca alkaloids. They're going to be working for this. So the first one, I mentioned, are the Taxanes. Anyone know what type of plant this is? The amateur botanist? I always like to bring up if a drug has a plant basis. I always like to bring that up just because I think it's an interesting tidbit you can wow your friends with. You forgot on the tip of your tongue. It's actually a Pacific yew tree, so not a me tree, but a yew tree, Y-E-W. That actually you find taxane-like derivatives in there, right? So again, it's interesting that we actually have anti-cancer drugs that can actually come from these natural sources, right? Just like you get, say, aspirin from the willow bark, you can get cancer drugs from some of these plants here. I'll show you a few more examples of that going forward. But we have paclitaxel and docetaxel. Those are the two taxane drugs. And essentially what these are going to do is they actually promote the formation of the microtubules, but you can't break them down once they're done doing their job. And so because of that, they will interrupt the mitosis process and prevent it from carrying on to completion there. So basically, you get these non-functional but very stable microtubules that can't really do much at that point. So in terms of toxicity, and one thing I forgot to mention is I posted up a document on Canvas called Anti-Neoplastic Man, or Chemo Man, if you will. You can pull that up, and it's a handy way that has been used since time immemorial for PA students and pharm students and MD students and everyone else to remember common side effects of chemotherapy drugs. And so if you look at him, he's very strange looking, but he's very effective at helping you memorize sort of what common side effects you'll see with these drugs here. But again, myelosuppression is going to be big, just like we've seen with the other antimetabolites already. Interestingly, though, docetaxel can cause some fluid retention, so this may not be great if you have conditions like CHF or maybe liver dysfunction where you have ascites developing that can worsen that. And then paclitaxel can actually cause some degree of peripheral neuropathy, so you do want to be watchful for that. Make sure you're testing, make sure the patient's sensation is not changing as time goes on. They're not complaining of tingling and burning sensations, things like that. And also, you may find that they can cause hypersensitivity, meaning like anaphylactoid or anaphylactic reactions. Now, we've talked about how to treat anaphylaxis already, right? What are kind of the main sets of drugs we use there? Epinephrine, right? What else? Diphenhydramine or Benadryl or antihistamines, right? In general, what else? So we mentioned antihistamines already. What else? Steroids, right? Corticosteroids are also going to be another big player there. And so in some cases, what we'll actually do is we do pre-treatment. So if we know that a drug is likely to cause some of these hypersensitivity reactions, we can actually pre-treat it. And so you may find that you'll have a dose of corticosteroids like hydrocortisone, prednisone, dexamethasone may be given as pre-treatment in order to help prevent that from actually occurring with these drugs. Maybe give it 15-30 minutes beforehand. It helps to offset some of that. Certainly, though, you'd also want to have standing orders ready for things like the epinephrine, the Benadryl, things like that. Because a lot of times patients are getting these either inpatient in the hospital or they're just going to an infusion center where they're getting these administered. So there may not be a provider right there on the unit at the time the patient's getting the medication, and so you want to have standing orders available so that way the nurses can respond in case there is a reaction. So if the patient starts to complain of their throat feeling like it's closing off, they already have orders for epinephrine ordered and ready to go that they can go ahead and administer. They'll still give you a call, but they at least can act on it immediately instead of waiting to call you up and then maybe you're in the bathroom, they wait 10 minutes, the patient's like, you know. So in those cases there, that's why standing orders for this stuff is really, really important. Next we have the Vinca alkaloids. You know what these are? Nothing at all. Periwinkle plants. So the periwinkle, it's nice kind of purpley pinkish sort of flowers here, actually contain Vinca alkaloids. There's three in this group here: vincristine, vinblastine, and vinorelbine. So it's easy to tell if it's a Vinca alkaloid because it'll have vin in the name there. Vincristine is probably one of the most common ones that we administer, at least over at Nemours, is one I deal with most frequently. This one, instead of with the taxanes actually causing those really stable microtubules and preventing the breakdown, this inhibits the actual formation of the microtubules in the first place. So again, you're preventing the microtubules from forming, thus mitosis cannot undergo mitosis there, right? So what you're going to find is, in terms of toxicities with this one, a big thing to note with this drug, you cannot give it intrathecally. If you accidentally give it intrathecally, you will kill your patient. So it's kind of a unique sort of thing there. It's not often I say, if you give it this way, you will kill your patient. This is one of those ways, okay? So a big kind of notable thing with that one. And it's important. You may think, well, how would anyone accidentally give this drug intrathecally? I'd have to get a lumbar puncture. That's a big deal. Like, how do you think this might happen?
There's so many drugs.
Yeah, you might be administering multiple drugs at the same time. So very frequently, a patient will be getting IT methotrexate the same time they're getting IV vincristine. So what would happen if you had two syringes there, medications are labeled, but you mix them up, right? So obviously we make this big warning because someone's probably done it accidentally and killed the patient, right? So we do things, put things in place to make sure that does not happen. So for instance, for our ITs, they always come in a syringe, right? A syringe you'd actually hook up, basically place a catheter intrathecally and you can hook up a syringe to that and administer it. Vincristine and the other Vinca alkaloids, we never put into a syringe. We always put it into like an IV bag. That way it's very difficult. Visually, you can't even mix them up in those cases there, right? So little things we do to try to prevent med errors from happening, and that can include just kind of what container we actually put the drug in sometimes, right? But anyway, so again, very fatal if given intrathecally. Do not do that. And then other things you can find, again, myelosuppression is a big thing. With vincristine, though, you'll find that neurotoxicities is another kind of notable one. So you get the hand-foot distribution there in terms of neuropathies. And kind of another unique thing as well is actually this ileus and paralytic ileus and constipation. And so we have one patient who will come in, and actually the doc won't even sign the orders for vincristine. They'll come in and kind of assess the patient because he has had issues of constipation previously. And so again, it's a very good drug for him, but tend to find that the constipation gets worse. You don't want to really give much more drug because it can just worsen that outcome there, right? And then the last thing here, these are vesicants. Anyone know what a vesicant is? Vesicant is basically a set of drugs that if they go outside of the vein that you're administering the drug in, it can cause severe tissue necrosis and tissue injury, okay? What do you call that when a drug accidentally goes outside of the vein? Extravasation, right? Extravasation, right? So extravasation can occur, and so this is why it's really important to make sure that the patients have good established lines. Very frequently, these patients are coming in often in order to get IV medications, so they'll have what they call an implantable port. They'll actually have something placed underneath the skin. The line will actually go and dump out into the vena cava, so it's a basically central access for that patient there. They will access that, and again, that helps to decrease that risk for extravasation when they administer via port. And so, again, you have to be very careful. I'm not going to talk about how we treat extravasation with these vesicant agents. There's actually different regimens out there. Some drugs you want to apply heat to it. Some drugs you want to apply cold. Some drugs you want to apply other drugs to it. But just know this is a strong vesicant. We'll cover a few more of these as we go forward. All right, so next up, so we talked about the mitotic spindle inhibitors, and now we're going to switch over to talking about topoisomerase inhibitors. Now, we've talked about drugs that inhibit topoisomerase before. Anyone remember where that happened? Antibiotics, yep. Which ones? Fluoroquinolones, right? So you'll start to see that there are some parallels between antibiotic drugs and chemotherapy agents here, right? Just like with, say, for instance, methotrexate, what was kind of the analog for that in terms of antibiotics? Folic acid antagonist. Actually, Bactrim, remember, sulfamethoxazole and trimethoprim inhibited the bacterial cells from utilizing folic acid, right? So again, you can kind of see some parallels between these if that helps kind of keep straight some of the mechanisms in your mind, that can be useful here. Now, our human cells, they have topoisomerase 1 and 2. I'm not going to get into the depths and ask you specifically, does this one affect 1 or 2? I do expect you to know that it affects topoisomerase. And the big thing this does is normally, what does topoisomerase help us to do? Yeah, it'll either cut single or double strand breaks in the DNA and allow for unwinding and rewinding of the DNA to occur, right? Because normally the DNA is very, very tightly wound, but if you want things like DNA polymerase to act on it, it has to unwind itself a little bit and get kind of loosened up so it's a little bit easier to work with. When you inhibit this enzyme, you end up increasing the number of strand breaks in the DNA, and after a while it becomes so difficult for the DNA polymerase to fix it that it just says, you know what, forget the cell, we're just going to trigger off apoptosis and we're getting it out of here, right? So that's how it's going to be end up triggering cell death in those cases. There's 3 main groups of drugs we'll talk about in this group here. It's going to be the epidophylotoxins, which is kind of a mouthful. We'll have the anthracyclines, and then the campothecins are going to be the 3rd class here. So the epidophylotoxins actually comes from the mayapple plant. So again, not quite as well known as like things like the periwinkle, but it's another plant-based one here. We're going to see etoposide and the tenipicide are the 2 drugs that fit into this category here. And basically, you're going to find that although they do have some ability to inhibit microtubule formation, the big thing they're working on is topoisomerase 2. So they're inhibiting that enzyme, increasing the number of DNA strand breaks, increasing cell death in those cases there. Again, you can see that dose-limiting myelosuppression is going to be a big thing. This is another count-dependent sort of drug, right? We want to make sure their neutrophil count gets up to a certain point before we give more of it. Nausea, vomiting, alopecia. Now again, not every single chemotherapy agent is going to cause alopecia. Some of them have more propensity than others. So you may find some patients are receiving active chemotherapy and they have a full head of hair. Totally normal, right? It just depends on the drugs that they're receiving there. But this one is a little bit more commonly known to cause alopecia for those patients. Next, we have the anthracyclines. And so we have 3 in this category called doxorubicin, daunorubicin, and the mitoxantrone. Again, if you ever see a patient who's receiving a chemotherapy agent, it's a bright red bag. That's usually going to be one of these drugs here because they actually are very kind of bright red in color when they're administering it. So again, these are going to work to inhibit topoisomerase. This actually does an interesting thing too. If you kind of notice the structure here, it's very kind of planar, and one of the things it can actually do is it sort of insert itself between the strands of DNA. It's called a process called intercalation, which you can kind of see here. It's just a fun word to say. But that causes disruption of the association between the nucleotides there, and will end up causing, again, further damage done to the DNA. So it's kind of another mechanism that's unique for the anthracyclines. And then there's something called free radical production, right? So what's a free radical? Anyone know? Besides my band name in high school. Yeah, it's an oxygen molecule that has a free electron, right? So it's a highly reactive oxygen species. ROS is reactive oxygen species, and it can bind to all sorts of things. It can bind to DNA, denature it and cause damage. It can bind to proteins. It can cause all kinds of damage to cells. Very, very highly reactive, and that can cause a lot of damage done to cancer cells, but you'll find that also can cause a lot of damage to our cells as well. Say, for instance, you have, if you imagine something like hydrogen peroxide, H2O2, and that breaks down into that hydroxide molecule, 2 hydroxide molecules. It's very reactive until it turns into water and oxygen essentially. But you're going to find that it's highly reactive, and that's why it works on, as an antiseptic agent. Same thing's happening here. You have this free oxygen with a free electron, it binds almost to anything and can cause a lot of oxidative damage. So in terms of that, what you're actually going to find a unique side effect of the anthracyclines is actually going to be cardiomyopathy and CHF. Basically, our cardiac cells don't really have a lot of this enzyme called this dismutase enzyme that can actually detoxify those free radicals, right? Normally, we have a lot of antioxidants that can help deal with that, although our cardiac cells don't have that ability. And so what you end up finding is that you can develop this cardiomyopathy and eventual CHF that can develop from administering these drugs. And what's interesting, this is actually a unique thing for these drugs, there's a lifetime max dose that you can receive. Right? So once you hit a certain amount of this drug, you can never receive any more of it because that risk for developing cardiomyopathy tends to be too high. Okay? That doesn't mean you can't get it too early. You can get it earlier. Some patients do, especially if they have existing CHF that can further worsen that, right? So you have to be really careful in terms of that. You also need to do things like a baseline echo. You got to know where they're at the beginning and be able to follow up with that in order to monitor it further, right? So again, if I'm asking about things like monitoring parameters, an echo would be one of those things that would be unique to the anthracyclines, right? You want to know, again, what their ejection fraction is looking like. Are they developing that cardiomyopathy? Okay. Again, you can find red discoloration of the urine and the sweat. Makes sense based off of the color of the drug itself, for sure. Anyone know any other drugs that causes urine or sweat to turn red? What we talked about? Hmm?
The TB medicine.
Which one?
I forget what it's called.
I forgot what
It
it's
starts with an R.
Rifampin actually can cause that. Yeah, I don't think we got into TB too much in this class here, but rifampin is another one that commonly causes that. The anthracyclines are also really strong vesicants, right? So again, this is another group along with the Vinca alkaloids that tend to be pretty strong vesicants. You do want to be cautious with that. Now this one is another one that has an antidote. So again, good thing to know. This is called dexrazoxane or Zinacard. This is actually going to be a chelator. Let's say chelator. What does that mean? Binds to things, right? So kind of think about like a crab kind of pinching in and grabbing something. Basically, it helps to prevent that free radical generation, so it tends to be cardioprotective. And actually, patients that are receiving dexrazoxane, they can receive a higher lifetime max dose than they would be otherwise by itself because of the fact that it will help to prevent some of that free radical generation, will prevent some of that cardiomyopathy from developing. Okay. Then we have our camptothecans, you have topotecan, and then irinotecan. And so these are working again on topoisomerase to inhibit that, increasing the strand breaks there. Now both of these are going to cause pretty significant myelosuppression, which again will be count dependent for those patients there. And actually what you're going to find is that, especially with irinotecan, to a lesser degree with topotecan, it actually is inhibiting cholinesterase activity. Now what does cholinesterase do? Breaks down acetylcholine, right? Good. So if I have more acetylcholine around, what is that going to end up increasing activation of? Well, it's one of our autonomic nervous systems. Parasympathetic nervous system, right? The rest and digest system is going to be sort of an overdrive because of this, because you have a lot more acetylcholine around. What type of receptors are those? Muscarinic receptors, right? So muscarinic receptors are going to be overstimulated, and so it's going to cause a lot of the side effects you would see with that. Anyone remember the mnemonic? I don't know if anyone watched that video. That's the anticholinergic toxidrome. What's the cholinergic side of things? Might have been one of the videos I posted up. So it's called dumbbells. Dumbbells is going to be the side effect profile. This is a good mnemonic to remember. This will help you out in case you get a question like this on the boards or something like that. So dumbbells, okay? So basically when you have something that's increasing cholinergic activation of those muscarinic receptors, you're going to have essentially fluids leaking out of everywhere, okay? So to go along with that, what do you think happens to the GI tract? Diarrhea, so that's the D in dumbbells, right? What do you think the U is? Fluids coming out everywhere. Urination, right? So they may become incontinent because they're urinating more, right? And what the M means, what did it do to the eyes? Mydriasis, or think about you're in your rest and digest state. I don't need to see a lot of danger coming in. Meiosis, right? You can see meiosis develop there, okay? And then we have what we call the killer bees. And so that includes things like bronchorrhea, so you can develop more bronchial secretions. Bronchospasm, meaning you can cause constriction of the smooth muscle in the lungs. And what do you think it does to the heart? Bradycardia, right? So again, slows down the heart. So bradycardia is another thing you would see with that. So those are the 3 B's in the dumbbells. Again, spelling is not important here. It's more about the mnemonic to remember that, right? E, going back to the GI tract, it's not coming out the bottom end. It's going to come out the top end, causing emesis, right? So you see emesis with that. How about with the eyes, again, going back to, say, fluid production in the eyes? With LB, lacrimation gets it. Lacrimation, we're tearing a lot. You say, why are you so sad? You say, that was muscarinic activation. I'm just crying a lot, right? And then how about the S? One more thing with the GI tract. What type of secretion? In the mouth, particularly? Salivation, right? Good. So defecation, urination, meiosis, bradycardia, bronchospasm, bronchorrhea, emesis, lacrimation, salivation, right? That's the cholinergic, that's a muscarinic mnemonic to remember the side effects you're going to see with that, okay? So anyway, getting back to our camptothecans, because it's decreasing cholinesterase activity, diarrhea is very, very prominent with these patients when they're getting irinotecan, more so than topotecan, but certainly it's a big thing you're going to see there. And in fact, we'll give them medications that actually help to decrease activity of the GI tract, which we'll cover in the final section here probably next week when we end up getting to that. Or not next week, the following week, because I won't be here next week. You should not be here either. Hopefully you're out there promoting capitalism by spending money on Black Friday and not here, right? But anyway, you're going to find that we'll talk about those drugs that help slow down the GI tract that can help to limit that diarrhea there. Okay. Okay. So that's it for the topoisomerase inhibiting drugs. Now we're going to get into another big category here called the alkylating agents. So everything we've kind of looked at so far has been more focused on cell cycle specific activity, right? So S phase, M phase, mainly where those drugs have been working at, right? So say for instance like the Vinca alkaloids, the Taxanes work more in the M phase, a lot of the other ones tend to work more in the S phase there. The alkylating agents are going to be non-cell cycle specific, okay? And so we're going to find this is the oldest class of drugs we have. They are very effective at what they do, but they are super toxic. They're really nasty because again, they're going to be affecting even cells that are in the G0 phase. They're still going to be affecting those cells, okay? So it's very, very toxic here. And actually, they got their start way back in World War I, back when mustard gas was a potential use as a chemical warfare agent. Those mustard gases are basically the alkylating agents we use now. We'll talk about our nitrogen mustards that we use. This is where it actually comes from. So again, these are poisons that we're giving patients, but again, the idea is to try to kill off as many cancer cells as you can and try to retain as many healthy cells as possible. Essentially what they're going to do, and again, all the ones we're going to talk about in this category work similarly, is that they're going to cause these covalent bonds to occur either between nucleotides in the same strand of DNA or cross strands. It can be inter or intra-strand binding that occurs there. And again, it causes deformation of the DNA to where it's causing more damage, causing more strand breaks, eventually triggering off apoptosis, right? All ends up leading to apoptosis of that cell there. And so again, they're non-cell cycle specific. It can affect just about any type of cell possible, so the toxicity is going to be pretty severe with these ones. So we'll look at some ways we can try to get around that. They're also mutagenic, so they can cause cancer potentially, cause new types of cancer. They're teratogenic, which means what? Anyone know? Not good for babies, right? Because they're going to cause bad changes for them. Carcinogenic, myelosuppressive, and also you can end up seeing there's one in particular that causes this, but in general you can find that pulmonary fibrosis is also another big risk. So maybe you want to monitor PFTs at the beginning of therapy, monitor them as they go along to make sure they're not going to develop, because this could be potentially fatal if that does progress. So getting into it, and you can kind of see what this looks like in terms of how the nitrogen mustards work. And this is again how all alkylating agents are going to be functioning, where they're going to be able to form these covalent bonds with guanine. You can actually see the strand connection here. It's covalent binding between the two nucleotides. Now, if you imagine DNA polymerase kind of coming along the chain there and trying to interact with that, it's kind of like a roadblock there. It can't really do much else with that because of that that modification that's occurring there within the DNA. Now, in terms of nitrogen mustards, I implore you, do not put this on any of your hot dogs. Okay. We have cyclophosphamide and ifosfamide. Those are the two main nitrogen mustards here, with very old drugs that we have. Again, we can use them to treat a lot of different types of solid tumors, hematologic cancers. And one thing you're going to find is kind of unique with this set of drugs here is they form a toxic metabolite called acrolein. And acrolein itself actually likes to get down into the bladder and can cause damage there. It actually causes a hemorrhagic cystitis. Okay, and so the one thing we can do to help prevent that is one, to make sure we're really hydrating the patient well, but you also can end up giving an antidote called Mesna. And Mesna is actually going to be able to bind up that acrolein and prevent the bladder toxicity you can see with that, right? So you could have gross hematuria, which you'd be able to very easily see, say if they had like a catheter in place or something. But you may look at the UA, you can find blood there as well, right? It can maybe less overt, you'd only see with the lab value. So again, this is why we give Mesna along with cyclophosphamide and ifosfamide. Yes, sir. It's a very good question. So it depends on the situation. So for instance, like it depends on, like with methotrexate, right? I'm not going to give every patient who gets methotrexate leucovorin. If they're on a really high dose methotrexate regimen, then yeah, they get leucovorin. But they're on relatively low doses and they don't get anything, right? Here, with this one, we always give Mesna along with cyclophosphamide. We know the risk is high enough that we automatically go ahead and give it. And in fact, when we compound it, we actually put the Mesna into the same bag as the cyclophosphamide. And we'll give them some subsequent doses a couple hours later. Yeah, very good question. Just depends on the drug and on the side effects you're expecting to see. So other things, you can see renal toxicity, myelosuppression. You tend to see more alopecia with the alkylating agents because, again, they can affect hair cells a little bit more specifically. Again, very high in terms of emetogenicity. A lot of the alkylating agents are very high on the emetogenic potential scale. They're going to require a lot more drugs in order to manage that. And again, we'll talk about antiemetic drugs going forward, but if you have a normal nausea, vomiting, maybe related to say a GI illness, you maybe get one drug for this. Some of these patients are like 3 or 4 drugs just to manage their nausea and vomiting. It's so bad for some of these patients. Here's the group of drugs called the nitrosoureas. Again, same mechanism, but here they may work a little bit differently in terms of some of their side effect profiles. So we have carmustine and lomustine. It's BCNU and CCNU. Again, like how carmustine gets turned into BCNU in terms of an acronym, who could say? But what you're going to find here is that this ones are actually interesting because the myelosuppression is very, very severe for this group of drugs, and it can actually be delayed up to 4 to 6 weeks after you give the actual drug itself. So you may not, and when I say nadir, anyone know what that means? It's basically the lowest point that the myelosuppression is going to hit, right? So again, it can be delayed. Sometimes with certain alkylating agents, maybe it's a few days after you administer it. Here, it could be delayed by up to 4 to 6 weeks, meaning that you may not really see the extent of that myelosuppression until much, much later. And it can last up to 2 weeks, right? So that's a long time. The patient could be at risk for an infection. Now, is it just bacterial infections I'm worried about? No. What else am I worried about? Fungal infections. What else am I worried about? Viral infections. I'm worried about, things like TB are more at risk for these patients, right? Any of these things you have to really, really be cautious with. Any type of infection is possible. And again, it's usually not the cancer that kills them, it's the infections they get due to the therapy itself. This is actually kind of an interesting thing I just put up here, a unique sort of dosage form. This is called a gliadel wafer. It's carmustine, and basically this is a patient who's had a brain tumor removed, and then they have these wafers they can actually place right here along the actual where the resection actually occurred, and they basically put it flat back over it, and then they let the patient go on their way, right? So why do they think this is kind of beneficial for the patient there? Yeah, so in case the surgeon missed any of those cells that are in there, which presumably he did, they put that on there along the margins, so that way you can get any of those cells. Kind of working a little bit more locally, it may help to limit some of the systemic side effects you may see for those patients there, right? So and there's some cool videos you can go and check out on their website. You can see kind of how the surgical process and all of that. Sorry, excuse me.
Go ahead, sorry.
For our test, you don't want us to know that like this will be used to treat brain cancers?
I would very unlikely ask a question about brain cancers and which one you would use there.
Okay.
I just more just to kind of illustrate some of the different utilities of it and different ways you might use the drugs. Yes, ma'am.
Is there any risk of having like brain cell death, like actual healthy brain cell death?
Yeah, probably some of those cells are going to die off too, right? So you could see CNS side effects associated with that. But again, risk versus benefits, right? Also got a lot of extra neurons around that can help to, shore it up, but you could see some side effects from that. Again, patient dies from brain cancer, bad. Maybe some CNS side effects, maybe preferable, right? So it just depends on the situation. Next off, we have drugs that are really only good for patients who have like really good health insurance, right? Because you got to be able to afford the platinum. Just kidding. These are basically drugs that have platinum included within them, and it's part of how they're causing those strand bindings to occur. And again, it could either be interstrand, could be intrastrand. Doesn't really matter. It's doing the same thing essentially, right? Causing deformation of that DNA, causing further strand breaks and damage. Here we have 2 drugs, or 3 drugs, and it's easy to tell if it's a platinum-containing agent because it has plat in the name. So you have cisplatin, carboplatin, and oxaliplatin. And again, same thing effects is causing here in terms of the other alkylating agents. This one does cause pretty significant nephrotoxicity, so you have to hydrate the patient really well. Patients may be getting hundreds of mLs of fluid an hour, well above their maintenance rate. If you think of like a normal maintenance rate, say for like an adult patient, what? Of IV fluids? I talked about that. All right, how do we calculate it for kids? That 4-2-1 rule, right? Remember that? So say for instance, like, a kid may be getting like 60 mLs an hour as in terms of their maintenance fluid rates. We might be giving them like 250, 300 mLs an hour. Their kidneys are good. We know they can flush that stuff through. And so we can just kind of flood them and make sure that we process that cisplatin through as well, right? So that way it doesn't stick around and cause renal toxicity. Also, this one also causes ototoxicity as well. So you have to check for hearing to make sure, again, a baseline follow-up to see how that's progressing there. Peripheral neuropathies are also a risk. Hypersensitivities. And again, these are some of the worst ones in terms of causing nausea, vomiting. These are very, very severe metagenic potential with these ones. Some other alkylating agents, things like dacarbazine, temozolomide, again, working not only to affect things like DNA, but these also can affect RNA, other protein synthesis, right? So it can be kind of more wide-ranging in terms of the effects it's going to have there. Vomiting, myelosuppression, alopecia, super common with the alkylating agents. Now, busulfan is kind of interesting because this one is most notable in terms of being the biggest risk for causing pulmonary fibrosis. So if a patient is receiving busulfan, you really got to monitor PFTs, make sure you're monitoring for that, see how the pulmonary fibrosis is developing, because we know it's going to happen. Much higher risk for this one occurring than other alkylating agents. And seizures might also be a risk as well. So we want to make sure if they have a history of seizures, this may not be a great drug for those patients. All right, so those are the alkylating agents. Any questions on those? All right, let's talk about a few miscellaneous agents. So we can actually use hormonal therapy to our benefits as well. We talked about how like estrogens can cause things like breast cancer, and testosterone causing that prostate cancer. Well, here you're going to find that we can actually use different hormonal therapies for our benefit. So, we may find that by using anti-androgens or anti-estrogen agents, that can actually be very effective for helping to, either by blocking the receptor or blocking production of the hormones, they can help to limit a lot of the stimulation on those tissues there. And so you can find that there's some significant side effects associated with those. So for instance, if I give a patient a drug that inhibits the production of estrogen because they have breast cancer, what kind of side effects would you expect to see? Basically, it's like putting them into a chemical menopause, right? So you can see hot flashes, you can see menstrual irregularities, you can see all kinds of issues with that. Also, normally estrogen and testosterone have positive effects on the bone to increase bone density. So if I'm inhibiting that, you run the risk of what? Osteoporosis, right? Fractures, things like that. So again, you have to be really careful with this stuff. We'll talk more about some of these agents when we get into like urology, and we talk about things like OB-GYN. We'll get into some more of those agents more specific. I might talk about a few of them here. Also, other hormonal therapies, we can actually use corticosteroids. Now, corticosteroids typically do what to your immune system? They suppress it, right? So it makes sense that if we have something like a leukemia, we can use corticosteroids to actually suppress production of new white blood cells. And so we can use things like dexamethasone, prednisone, and that will actually help out a lot with that. Not only that, but also you can find that the corticosteroids are actually really helpful for treating chemo-related nausea and vomiting. So you frequently may see a patient who's getting it just around the time they receive other chemotherapy drugs, and that's related to the nausea and vomiting. So some of them can provide sort of a dual sort of benefit there. Briefly, I want to mention the biological response modifiers. Now, basically, we have a lot of proteins here called the tyrosine kinases, and I probably briefly talked about these in the Intro to Pharm class way back in the summer. Most of you have probably repressed those memories already and have years of therapy waiting to come to you to work through those. But we have a lot of tyrosine kinases, and they're really responsible for causing a lot of different types of growth within the cells. So, for instance, we have insulin receptors that are tyrosine kinase receptors, and these provide unique sort of targets to attack these cancerous cells in order to help limit their growth potential, right? So for instance, if I can help to decrease the angiogenesis to get to these cells, by cutting off the nutrient supply, you inhibit their growth as well. And you can find that certain types of cancer cells may overexpress some of these proteins here that we can then target, right? And so, again, how they would normally function is, again, you have two of these tyrosine kinase receptors, you have the molecule come along and bind to both of them, they then get phosphorylated, and then they cause whatever cellular response. So if it's an insulin receptor, it causes glucose receptors, transporters to go up to the cell surface, it may cause mitosis to occur. And these can provide some unique targets for our chemotherapy drugs. And just another example showing you how the wide-ranging the effects of these tyrosine kinase receptors can be in terms of causing cell growth and stimulating production of these new cancerous cells. And so here's an example where we can actually use mutations in the actual cancer cells to our benefit, to be almost like using, instead of imagining like an alkylating agent, like throwing a hand grenade and kind of getting all kinds of casualties, innocent casualties in addition to cancerous cells. This is like using a sniper rifle, very, very particular, very targeted. And so for instance, we have a drug called imatinib, or Gleevec, and actually is able to be used for different types of chronic myelogenous leukemias. And so for instance, if you have this BCR-ABL mutation, if you have this one particular type of mutation, you can give this drug to those patients and have very significant effects to decrease proliferation of those cells. Okay? Now, if you don't have that mutation, guess what the drug's going to do for you? Nothing, right? And look at the side effects: a little bit of nausea, a little bit of vomiting, maybe some edema. Pretty beneficial, or pretty, preferable to something like carmustine, lomustine, things like that. So you usually mitigate a lot of the myelosuppression, usually eliminate a lot of the alopecia, mucositis, things like that come along with a lot of your standard chemotherapy drugs. Here's one we could use for non-small cell lung cancer, where it's actually affecting this epidermal growth factor. So again, very, very targeted. You limit a lot of that toxicity, but it's very niche, right? You can't just use it for every patient with lung cancer. It's going to be for very specific ones, okay? So again, one way we can actually get around and be much more targeted in our approach there. Here's an example of a monoclonal antibody we could actually use in order to target specific types of cancers. So for instance, we have rituximab. And when I say MAB, that means monoclonal antibody, right? So you already know some risk for giving these drugs. What's that? Anaphylaxis, absolutely. Anyone know what the XI means here? This is a chimera. Basically, we're mixing human and murine protein. Murine means what? Mouse, right? So you're actually mixing those two together. And again, anytime you have more foreign protein, your risk for anaphylaxis does go up, right? So you want to be careful of that, unless your patient happens to be mouse, and then they might be okay when they receive this. But most of your patients are not mice, and so in these cases here, rituximab is actually targeted against CD20 specifically. So if you have these beta lymphocytes, say you have non-Hodgkin's lymphoma, about 90% of those patients will develop will have cells that actually express CD20. So by giving rituximab, I can target that specifically. And again, it's an antibody, right? It's going to bind to that, and then it activates the complement system and activates the immune system to then target those cells and then get rid of them. Okay, so again, very effective, much more specific for just those kind of cells that express that receptor, and it will help to spare other cells. Okay, so just another way we can be a little bit more targeted with that. Again, you'd have to be careful watching out for anaphylaxis. You'd want to have pre-treatment typically for those patients there. We actually give this a lot for patients like certain types of rheumatoid arthritis and things like that. So depending on the dose and how you're using the drug can either be very good for cancer or it could be good for other rheumatologic conditions. If your patient does want have a hankering for cheese after this, that's totally expected. Okay, just kidding. Anyway, but again, these are going to be things that are typically given as, say like a weekly infusion, right? So they come into the infusion center, get it there. You want to have the patient there in the center so that way you can monitor for signs of anaphylaxis, right? So make sure they're not going to have a reaction to that. And it will get infusion-related reactions, right? So they're going to get, because you're activating that immune system, you're going to get myalgias, you're going to get low-grade fever potentially. And so we can pre-treat with things like Tylenol. We can give them things like steroids potentially, depending on if they had reactions before. So again, there's a lot of other drugs that are out there to fit these conditions. Again, I don't want to get too in the weeds with those because they're constantly multiplying, and again, I only have so much time to talk about them. But some of the other kind of ancillary things I want to mention here before we finish up, in terms of dosing and administration, I mentioned a lot of these are going to be count dependent, meaning you have to give the hematologic system time to recover before you hit them with another round of chemotherapy, which is why they go through this sort of cyclic administration there. And so again, you have to monitor for platelets. We know the platelets are down, they're at risk for things like bleeding, so you have to watch out for that. And you have to watch their absolute neutrophil count. You know how to calculate that? So you get a CBC with diff. Some places will actually tell you specifically what the neutrophil count is, and they don't have to do any calculations. A lot of times, though, they'll express the CBC with differential in terms of percentages. And so say, oh, you have this percentage neutrophils. You basically just multiply that percentage times their overall white blood cell count, and that will tell you their absolute neutrophil count. And so, for instance, if it's below, say, for instance, like 750 count, then we would not give the chemotherapy, right? It's just one example there. But other things you're going to look out for: look at their renal function, look at their urinalysis, make sure the specific gravity is right for things like methotrexate. Look at their hepatic function. You got to monitor for these things to see how they're changing as time goes on. And again, watch how the drugs are actually being dosed there. We mentioned BSA is probably one of the most common ones that I use, at least for pediatric chemotherapy. Sometimes weight-based, sometimes even age-based. We saw, if you look at that roadmap, that methotrexate is intrathecal methotrexate. There is actually age-based dosing associated with that. So if you're like, say, 1 to 2 years old, you get 8 milligrams. If you're higher than that, then you get 10, 12, 16, whatever the case may be. Sorry, I thought someone said something. Anyway, so just be very wary with that. Make sure you get up-to-date heights and weights for your patients, right? So especially pediatrics, is that constantly changing? 100%, right? And actually, I have an example of this where my daughter, my 3-year-old, was recently went in to get a checkup done, her yearly checkup. And when they were actually measuring her height, she had like a little bun on top of her head, so they were trying to get the thing so they could actually get a measure of the height right. So they ended up having to like kind of crank her head sideways, and they used that height. So it was actually probably like an inch shorter than what she should have been. Sounds silly, but again, you're dealing with a 3-year-old who's like cantankerous to say the least, and then you have the nurse trying to wrangle her to stay still long enough to actually get the height, and then she has this little bun on her head to prevent that. It's a hassle, right? But that actually knocked her BSA way, or her BMI way off, right? So then it looked like she's in the 99th percentile for her BMI when really she's like perfectly normal, right? So you think the nurse would know that and be able to get a good accurate height, but whatever. Point being is that you have to be really careful with that, especially if you're dealing with babies, like, they tend to scrunch up, so it's hard to get an accurate height on them. Kids might not be wanting to stand still. Do they have their shoes on, shoes off? These are all things you have to watch out for. Now, in terms of safety and handling, now, are chemotherapy drugs just dangerous to the patients who are receiving them? Potentially they can be dangerous to us too as healthcare providers, right? So you may not be there, but the nurses may be there at the bedside actually administering these drugs, and so you have to be careful with that. So appropriate PPE has to be worn, right? And PPE stands for what? personal protective equipment, right? So like I have very low grade PPE on right now wearing scrubs, right? Is this going to protect me a lot from like say chemotherapy? Not really, right? It's like what they call class D PPE. However, if I'm wearing things like gloves, if I'm wearing like a face mask, some of these drugs, the patient may aerosolize potentially. And also think about it's not just the drugs you're giving them, but it's also their secretions as well. So if you're dealing with like a diaper for a patient who has received chemotherapy, that urine may be laced with chemotherapy. You have to dispose of it appropriately, make sure you're not going to be potentially at risk for being exposed to that as well. Because again, you can imagine as well, like a lot of nurses are younger, they're childbearing potential, they may be exposed, right? That could be a problem. May find that you as a provider may be at risk if you're exposed to that. So just be really careful of that. Us in the pharmacy, we're actually producing it ourselves, right? So again, we have things like we have hoods that actually have negative pressure associated with them, such that they suck air in, so that way we can't accidentally manipulate it and cause stuff to blow out at us, right? So we take a lot of precautions when it comes to dealing with these hazardous drugs. And then looking at some of the supportive care we can do for these patients. So we mentioned the myelosuppression is a huge issue with them. And so in some cases we can actually give them support for that and actually help them to bulk up their immune system by giving them hormones essentially to help stimulate that. So for instance, you can see that we'll give things like certain colony stimulating factors. Like maybe if they're anemic alone, we'll give them erythropoietin to help stimulate that production of red blood cells. Or maybe we'll give them granulocyte colony stimulating factor to help them generate things like their granulocytes, like their neutrophils, right? So these are things we can administer to them occasionally in order to help kind of speed up the process of them actually recovering after receiving chemotherapy, right? And again, sometimes you can find certain anemias can be for months afterwards because we know the lifespan of a red blood cells, 120 days, right? So again, it could be long lasting for those patients there. And we know that they're at increased risk for infection, for anemia, and for bleeding because of platelets, because of the red blood cell, because of their white blood cell count. This is a really big deal though. Make sure if you have a patient who's receiving chemotherapy, do not give anything rectally. Why do you think that is? Think about what are the cell lines we said are most frequently hit by chemotherapy? GI cells and white cells, right? So imagine you're taking a rectal probe to get a temperature on these patients because they come in with fever, right? Well, that tissue in the rectum is now more friable. Anyone know what friable means? Brittle. Brittle. It's easy to break, right? So it's potentially can cause breaks in the skin there, those epithelial cells, and then guess what? You introduce some of those GI bacteria into the bloodstream, and they're not able to fight off that infection, right? So again, it's a huge risk with that. You have to be really careful for those patients there. Nothing rectally administered, no suppositories, no rectal temperatures, no DREs, nothing like that you want to do for those patients there, right? Also think about things like, if they're in the hospital, people frequently want to go and see their loved ones. They want to bring them flowers. They want to bring them, gifts and things like that. Like fresh flowers have a lot of bacteria on them, so you don't want to bring that to them and potentially cause an infection to occur. Or we like to use fruit that you actually have to peel. So that way it gets rid of any kind of external sort of bacteria on that. So maybe like oranges might be good for them, or banana. Maybe something like grapes is not a great idea, right? So little things you may not think about in terms of taking care of these patients here. Okay. So anyway, again, the myelosuppression, big thing you have to worry about for those patients. The other thing is going to be the GI effects. So for instance, nausea, vomiting, very, very common. It's not just when they receive the meds, but it could be for days afterwards. Sometimes they have a kind of prolonged sort of emetogenic sort of phase there. And so we'll talk about antiemetics next, the following session we have there. But also think about things like mucositis, right? So again, those epithelial cells are not growing properly, so they can develop ulcers and sores. Very painful. Do patients want to drink while they have all those sores and stuff? It's not going to be painful, right? They're not going to want to eat either. So because of that, one, you can see infection in the mouth, so oral hygiene is really important. And then you may not end up having good nutrition. So some of these patients may have to go on what we call total parenteral nutrition, where we actually give them all their nutrients through an IV in order to help replace that. So again, good oral hygiene, we'll do things like salt rinses in order to help keep it clean, or we may do things like chlorhexidine, which is an antiseptic agent that can kind of swab the mouth with, and that can also help as well. Just to give you an example of the emetogenic potential of these drugs here, you're going to see that, again, depending on the agent you're receiving, the emetogenic potential can change pretty drastically. So for instance, high risk, meaning greater than 90% chance patient's going to have nausea, vomiting associated with that. It's pretty good odds, right, that it's going to happen. Things like your carmustine, cisplatin, cyclophosphamide, a lot of those alkylating agents were high up on that list there, versus maybe more moderate risk. Things like, let's see, doxorubicin, right, one of those anthracyclines we talked about, or irinotecan. And so depending on that, the regimen will change. So for instance, a patient getting a high emetogenic risk potential drug, they may be getting 4 or 5 agents to deal with nausea vomiting, versus here, for moderate risk, maybe you could get 2 to 3. So it'll depend on the regimen. We'll talk much more about those when we get into talking about the GI section next time. So any questions on oncology? Again, it's a brief sort of overview, but again, focus on the big things, the mechanism of action, side effects, drug interactions, we talked about that, antidotal agents, right? There's something unique with a set of drugs, like focus on that sort of thing. It's sort of high yield items that could be asked on the boards or on my test, right? Yes, ma'am.
So when I think Taxanes, you have the risk of anaphylactic shock, and then you also have the risk of bronchospasms. Is there some kind of a protocol? Do you know when you should see bronchospasms and after the epinephrine?
Yeah, so it depends on sort of like the severity of symptoms, right? So how fast it's coming on, how severe. If they feel like the throat's closing off, it's a little bit different than they have a little bit of expiratory wheezing, right? So it could just be as simple as I just give them an albuterol neb, and they're right as rain. I don't have to worry about it, right? But that's also why we pre-treat. We'll give them antihistamines beforehand. You may give them corticosteroids beforehand. So it's common, especially if they have a history of a reaction, we'll actually give them, like say, hydrocortisone, acetaminophen, and say diphenhydramine before they get the drug, and then we'll also have standing orders to give them steroids, epinephrine, and Benadryl if they do have a full-on anaphylactic reaction. Any other questions? Let me check the board here. No questions at all, so I'm assuming that I'm doing a great job and you just learned it all. Okay. If nothing else, I hope you have a wonderful Thanksgiving. Please take a well-deserved break. You get the whole week off? Or you gotta come, oh, that's we give our Nova students an exam on Wednesday. That's how mean we are over there. So I was like, ooh, that's rough. Rough. Anyway, huh? Okay, well, good luck on your exam. Enjoy your time off, and I will see you the following week. It'll be our last class session. Yes.